Our first speaker is Professor Hidetaka Wakabayashi. Professor Wakabayashi is affiliated to the Department of Rehabilitation Medicine at the Tokyo Women's Medical University Hospital, where he is currently working as a professor. He is the director and editorial board of the Japanese Association on Sarcopenia and Frailty. And he is the advocate of the concept of sarcopenic dysphagia and rehabilitation medicine. He will present for us and discuss the topic of dysphagic patients and their association with protein, malnutrition, and sarcopenia.
Hello, everyone. Today, I'd like to talk about dysphagic patients and their association with protein, malnutrition, and sarcopenia. I have two key messages today. First, sarcopenic dysphagia may be common in older patients with dysphagia. Second, rehabilitation nutrition is useful for preventing and treating sarcopenic dysphagia. I have 4 topics today: malnutrition and dysphagia, sarcopenic dysphagia, iatrogenic sarcopenia, and rehabilitation nutrition. First, I'll talk about malnutrition and dysphagia. In 1992, Beldi published a review article, "Can Protein-Calorie Malnutrition Cause Dysphagia?" They argued that protein-calorie malnutrition may negatively affect swallowing function. In 2000, Hudson published a review article, "The Interdependency of Protein Energy Malnutrition, Aging, and Dysphagia." This figure shows the interdependency of protein energy malnutrition, aging, and dysphagia. Older people tend to have high incidence of both dysphagia and protein energy malnutrition. And dysphagia increases the risk of protein energy malnutrition. The important point is protein energy malnutrition may increase the risk of dysphagia. A systematic review of malnutrition and dysphagia in stroke was published in 2009. The prevalence of malnutrition was 8.2% to 49%. The prevalence of dysphagia was 24.3% to 52.6%. In addition, malnutrition was higher in patients with dysphagia. Another paper about dysphagia and malnutrition showed that malnutrition or at risk of malnutrition at follow-up were associated with basal oropharyngeal dysphagia and impaired efficacy of swallow. Our study showed that head lifting strength, illustrated here, was independently associated with both dysphagia with aspiration and malnutrition, indicating the relationship among sarcopenia, dysphagia, and malnutrition. Furthermore, malnutrition risk and sarcopenia are common in patients with oropharyngeal dysphagia. In patients with oropharyngeal dysphagia with chronic conditions, the prevalence of malnutrition risk assessed by the MNA was 51.1%, and sarcopenia was 16.7%. In patients with oropharyngeal dysphagia with community-acquired pneumonia, the prevalence of malnutrition risk assessed by the MNA was 69.5%, and sarcopenia was 29.4%. So both malnutrition risk and sarcopenia are quite common in patients with oropharyngeal dysphagia. These studies indicate a close relationship among dysphagia, malnutrition, and sarcopenia, and iatrogenic factors may play an important role in this close relationship. Next, I'll talk about sarcopenic dysphagia. Sarcopenic dysphagia is defined as difficulty of swallowing due to sarcopenia of the swallowing and generalized skeletal muscles. The presence of dysphagia and whole body sarcopenia are necessary to diagnose sarcopenic dysphagia. This slide shows a figure of aspiration pneumonia and etiology of sarcopenic dysphagia. Presbyphagia is age-related changes in the swallowing in older people. Presbyphagia is frailty of swallowing. Presbyphagia is not dysphagia, but frailty of swallowing. Patients with aspiration pneumonia tend to be prescribed non-eating and bed rest during pneumonia treatment in Japan. Activity-related sarcopenia and disused muscle atrophy develop during non-eating and bedridden periods. Nutrition-related sarcopenia or starvation may get worse during non-eating periods by inappropriate nutrition care management in Japan. Also, disease-related sarcopenia gets worse by acute inflammation due to pneumonia. Therefore, older people with aspiration pneumonia can experience activity, disease, and nutrition-related sarcopenia, and resulting in the development of sarcopenic dysphagia. In basic research, aspiration pneumonia induced muscular atrophy in diaphragm, tibialis anterior, and tongue. You can see muscle atrophy in diaphragm here, tibialis anterior here, and tongue muscle here. Recently, ultrasonography has been used to evaluate swelling-related muscle mass, such as tongue and genial hyoid muscle mass. Our research showed that tongue muscle mass was smaller and tongue muscle intensity, that means quality, greater in patients with sarcopenic dysphagia than in patients without the disorder. Our case study showed improvement of genial hyoid muscle area here by rehabilitation nutrition and aggressive nutrition therapy in a patient with dysphagia. You can see the quite difference between day 19 and day 131 during admission. Genial hyoid muscle area increased in parallel with an increase in body weight and skeletal muscle index. Genial hyoid muscle area increased around 33% from 0.84 to 1.12. Body weight increased from 54 kg to 62 kg, 15%. And skeletal muscle index increased from 6.3 to 7.6, 21%. So genial hyoid muscle area increase in combination with increase in body weight and skeletal muscle index. Also, hand grip strength and tongue pressure also increased during hospitalization. This slide shows a figure of diagnostic algorithm for sarcopenic dysphagia. Aged 65 years and older and following commands are eligible for this algorithm. First, whole body sarcopenia was assessed by hand grip strength, gait speed, and general muscle mass. If patients do not have whole body sarcopenia, they are diagnosed no sarcopenic dysphagia. Second, swallowing function was assessed. If swallowing function was normal, they are diagnosed not having sarcopenic dysphagia. Next, whether the patients have obvious causative disease of dysphagia or not is evaluated. If patients have obvious causative disease of dysphagia, they are diagnosed not having sarcopenic dysphagia. Finally, swallowing muscle strength was assessed by tongue pressure using a maximum tongue pressure measurement. People with low swallowing muscle strength, that means tongue pressure was less than 20 kilopascal, were classified as probable sarcopenic dysphagia. People with normal swallowing muscle strength, or in case that tongue pressure cannot be measured, are classified as possible sarcopenic dysphagia. The prevalence of sarcopenia dysphagia in dysphagia rehabilitation in acute care hospital was 32%. Major causes of disease of dysphagia in this study are brain and nervous disease, cardiovascular disease, and respiratory disease. In contrast, major causes of diseases of sarcopenia dysphagia in this study were respiratory diseases and cardiovascular diseases. The etiology of dysphagia and sarcopenia dysphagia were quite different. The prevalence of sarcopenia dysphagia in pneumonia in patients with dysphagia was 81% in Japan. So sarcopenia dysphagia is quite common in Japan. Moreover, the prevalence of sarcopenia dysphagia in institutionalized older adults in Colombia was 45%. Therefore, sarcopenia dysphagia may be common in South America. In 2019, the Japanese Association of Dysphagia Rehabilitation, the Japanese Association of Rehabilitation Nutrition, the Japanese Association on Sarcopenia and Frailty, and the Society of Swallowing and Dysphagia of Japan published a position paper about sarcopenia and dysphagia. I will introduce treatment of sarcopenic dysphagia. Dysphagia rehabilitation, along with nutrition support, consisting of approximately 35 kilocalories per kilogram per day, determined using their ideal body weight, is recommended in this position paper. Indeed, an energy intake of more than 30 kilocalories per kilogram per day and protein intake of more than 1.2 grams per kilogram per day based on ideal body weight, not current body weight, increase tongue strength in older adults with sarcopenia. Moreover, providing more than 30 kilocalories per kilogram per day energy based on ideal body weight improves swallowing function more compared with providing less than 30 kilocalories per kilogram per day energy in patients with sarcopenia dysphagia. Nutrition improvement is very important to treat sarcopenic dysphagia. Let's move on to scoping review of sarcopenic dysphagia. We published diagnosis and treatment of sarcopenic dysphagia, a scoping review in 2021. I'd like to introduce a bit about this scoping review. Aim was to explore the currently known information on the diagnosis and treatment of sarcopenic dysphagia and to clarify the types of research required to develop the field. We searched the PubMed, Medline, SNAO, and Cochrane databases from the inception to October 2020. Results of scoping review: 21 and 8 articles reported on the diagnosis and treatment, respectively. This figure shows result of diagnosis scoping review. Diagnostic algorithm for sarcopenia dysphagia was most frequently used. Other diagnostic methods were consensus diagnostic criteria for sarcopenia dysphagia, sarcopenia and dysphagia without other causes of dysphagia, and both sarcopenia and dysphagia. Diagnostic algorithm for sarcopenia dysphagia was the most widely used and should be used because it is the only reliable and validated diagnostic method until now. Recently, a review article, Diagnosis of Sarcopenia Dysphagia in the Elderly, Critical Review and Future Perspectives, was published in Dysphagia. This review indicated that validation of diagnostic algorithm for sarcopenia dysphagia and video fluorography and/or video endoscopic findings in sarcopenia dysphagia should be examined in the future. This figure shows the result of treatment scoping review. There were only 8 single patient case reports. 6 case reports describe the combination of rehabilitation and nutrition support. 1 case report shows the use of an interdisciplinary approach, and another case report described performing moringa suspension and rehabilitation and nutrition support. These case reports show the importance of interdisciplinary rehabilitation nutrition for improving patients' nutrition status and sarcopenia. However, further evidence is required because there were only case reports and evidence level is relatively low. Next, I'd like to talk about iatrogenic sarcopenia. For prevention of sarcopenic dysphagia, it is critical to prevent iatrogenic sarcopenia caused by unnecessary inactivity or bed rest, inappropriate NPO, no oral intake, and inadequate nutrition management in the position paper. Nutrition sarcopenia is a result from inadequate dietary intake of energy and protein like these women. Treatment of nutrition sarcopenia is nutrition improvement, not exercise such as resistance training. Daily energy intake in acute care hospital required dysphagia rehabilitation was 648 kilocalorie. What do you think 648 kilocalorie means? The answer is 25th percentile. So in Japan, 1 in 4 patients took less than 648 kilocalorie per day. The worst patients took only 100 kilocalorie per day. In Japan, nutrition management in NPO patients, no oral intake with aspiration pneumonia was inappropriate. NPO patients on day 7 were 35% in Japanese database study in acute care hospitals. Moreover, only 5.3% of NPO patients were prescribed the recommended doses of more than 20 kilocalorie per kilogram per day. So nutrition-related sarcopenia due to inappropriate nutrition care management is common in Japan and should be called as iatrogenic sarcopenia. Iatrogenic sarcopenia is defined as sarcopenia caused by the activities of medical staff, including doctors, nurses, or other healthcare professionals in healthcare facilities, especially in acute care hospitals. There are 3 causes of iatrogenic sarcopenia: unnecessary inactivity or unnecessary oral intake restriction, inappropriate nutrition care management, and iatrogenic diseases and adverse drug events. I have to admit that some acute care hospitals in Japan may be sarcopenia manufacturing factories due to iatrogenic sarcopenia. Moreover, iatrogenic sarcopenia can have an important role in the close relationship among dysphagia, malnutrition, and sarcopenia. So iatrogenic sarcopenia is one of the causes of sarcopenic dysphagia and should be prevented for prevention of sarcopenic dysphagia. Prevention of iatrogenic sarcopenia and sarcopenic dysphagia should include early rehabilitation, early oral intake, and early appropriate nutrition care management based on appropriate evaluation in acute care hospitals. Next, I'll talk about rehabilitation nutrition. Rehabilitation nutrition is a combination of both rehabilitation and nutrition care management. It is defined as evaluates holistically by the International Classification of Functioning, Disability, and Health, ICF, and the presence and causes of nutrition disorders, sarcopenia, and excess or deficiency or nutrient intake, and conducts rehabilitation nutrition diagnosis and rehabilitation nutrition goal setting then it elicits the highest body functions, activities, participations, and quality of life by improving nutritional status, sarcopenia, and frailty, using nutrition care management in consideration of rehabilitation and rehabilitation in consideration of nutrition in people with a disability and frail older people. This is a definition of rehabilitation nutrition. Why rehabilitation nutrition is important? Because the prevalence of sarcopenic dysphagia in dysphagia rehabilitation was 49%. Sarcopenia is very common in older people who require dysphagia rehabilitation. Moreover, sarcopenia is associated with worse recovery of ADL and dysphagia and a lower rate of home discharge in convalescent rehabilitation ward. So sarcopenia improvement is important in dysphagia rehabilitation. This figure shows rehabilitation nutrition care process. High quality rehabilitation nutrition is provided by this care process. It includes 5 steps, that is, assessment and diagnostic reasoning, diagnosis, goal setting, intervention, and monitoring. It is important to turn this cycle several times. It is similar with management cycle such as PDCA cycle, plan, do, check, act. I will introduce SMART goal setting because SMART goal setting is most important in this care process. SMART means a goal that is specific, measurable, achievable, relevant, and time-bound. For example, nutrition improvement or dysphagia improvement are not a SMART goal. Increase 1 kilogram body weight in 1 month, or start oral intake and eat past food 3 times a day in 2 weeks are relatively SMART goals. It is important to set SMART goals in rehabilitation nutrition. Also, aggressive nutrition therapy is important in rehabilitation nutrition. Energy requirement in people with nutrition-related sarcopenia is energy expenditure plus daily energy accumulation to increase body weight and muscle mass. We call it as aggressive nutrition therapy. Without daily energy accumulation, body weight is not increased. Energy accumulation is usually set around 200 to 750 kilocalories per day. In older people, 8,800 kilocalories to 22,600 kilocalories are necessary to gain 1 kilogram body weight. Recently, our study showed that around 9,600 kilocalories is necessary to gain 1 kilogram body weight in patients with a stroke who need rehabilitation. So energy accumulation is important for treating nutrition-related sarcopenia. There are 2 key questions for aggressive nutrition therapy. First, should malnutrition be improved? Basically, malnutrition should be improved. However, in viewpoints of rehabilitation nutrition, if nutrition improvement can contribute to dysphagia and ADL improvement, nutrition improvement should be performed. Second key question of aggressive nutrition therapy is, can malnutrition be improved? In cases of cancer terminal stage, very strong acute inflammation, and refeeding syndrome or at risk of refeeding syndrome, aggressive nutrition therapy cannot be performed. If answers of these 2 key questions are yes, aggressive nutrition therapy will be performed. To conclude my talk, I'd like to highlight my key points again. Sarcopenic dysphagia may be common in older patients with dysphagia. Rehabilitation nutrition is useful for preventing and treating sarcopenic dysphagia. Thank you very much for your listening.